Certainly want to go over just a couple little, facts, some information that has changed, particularly since a lot of this transpired at the very end of 2022. So I want to get out there some information as we know it, and then introduce you to our panelists and really focus for the main part of this is to have a wonderful discussion about what this means for our community, the opportunities that lie ahead with Medicaid, the challenges. So just wanted to spend a little bit of time conveying some information that is particularly important in the next couple months, and want to take any opportunity to share it with you all. So I am gonna try and move quickly through these slides, and hopefully please ask any questions while I'm sharing the presentation. It's probably going to be hard for me to see the questions, but to my fellow panelists, please feel free to chime in if you want to relay a question, or certainly once we pull it all down, we'll have lots of time for conversation and discussion. So I am so fortunate to be joined with by an amazing group of individuals. I can't wait to get to have this conversation with them. We will, as I said, get to that as soon as possible, and look forward to each of them has a very different perspective and comes with amazing experience and really important wisdom to impart to everyone. So just to frame this conversation, the Medicaid redetermination has been on hold. So states have not been completing Medicaid redetermination since early in 2020. So as part of the public health emergency, states were required to keep people in Medicaid, which was known as continuous enrollment. And in return, states were getting an additional amount of money from the federal government for their Medicaid enrollees. So it benefited states to keep people enrolled in Medicaid. So now, just to note, states might have been doing behind the scenes looking at eligibility, but they were not supposed to clear people from their roles during this time. And so up until the end of 2022, the Medicaid redetermination process has been linked to the public health emergency. However, the big spending bill that was signed on December 23rd, which is known as the omnibus spending bill, were separated the public health emergency and the Medicaid redetermination process. So now Medicaid redeterminations are going to begin in 2023, and they will begin no later than April 1st. However, states do have the right to begin them as soon as February 1st. So that is, for those counting, we are talking 12 days away. So very, very imminent. States will have a total of 14 months. And the reason they give that 14 months is because they have 12 months to initiate the redetermination process, and then 2 additional months to complete it. So people who are initiated in that 12th month, they still have to have at least the 60 days to complete the process. So that's why you might hear sometimes people saying there's a 14-month period or a 12-month period. It is 12 months. In the 12-month period, everyone who is enrolled in Medicaid, so every Medicaid enrollee, will have to get notice about when their redetermination is going to happen. To make this even more challenging, every single state has their own process, because every state actually has different rules in how redeterminations go and what it looks like. So it makes it very confusing and very important to know what's happening on the local level. We will make sure that you guys have this information. This came from a CMS guidance and is really very helpful because it kind of lays out what those 14 months look like. As I mentioned, some states can start as early as February 1st in looking at what they call the unwinding or beginning the redeterminations again. So that top option A is what it would look like, what those 14 months would look like for states that choose to start on February 1st. They could also start on March 1st or April 1st, and that 14-month window will shift according to when they start. This is particularly important because this is when your states will start to cut people off from Medicaid. So states that start the redetermination process on February 1st, anybody who received notice that they were due for redetermination, they could lose coverage starting on April 1st, if they were if their 60-day redetermination window started on February 1st. So this is something that will be really important to know what your state is going to do, because when they start really matters, because it's going to be when people could start to lose coverage. And this is to make it even more complicated. Some states have a 60-day renewal process. Some states have a 90-day renewal process. And we will get either in the chat, or I'll make sure I'll get the link out to you, that has this timeline, this example timeline, because it plays out what those scenarios would look like. I want to talk a little bit about what is at risk. So the CMS has estimated that almost 7 million people who are still eligible for Medicaid could lose coverage due to administrative reasons, meaning they're still eligible, but something happens during that redetermination process. They don't get notification. They're unable to get the documents in. Their offices were too busy for them to get an appointment. They could lose coverage due to what we call an administrative reason, meaning they should be able to get back on Medicaid, but there will be a lapse in coverage. We know that BIPOC people are disproportionately enrolled in Medicaid despite having family members with full-time employment, because they are underemployed and below the threat. They have employment that does not provide insurance, and their income is below the threshold. So we know that this is going to disproportionately impact members of the BIPOC community. In addition, people experiencing homelessness are also disproportionately impacted by redetermination in general, because this is a communication heavy and puts the burden on enrollees traditionally. So we know that they are going to be disproportionately impacted and represented in that category of people who lose coverage because of an administrative reason. So because of that, healthcare is likely to be interrupted or discontinued. There will be people who are unable to complete the redetermination process because it has been 3 years since they've had to do this. And it is not on people's radar the way it was previously to have to complete this process.
Mm-hmm.
And with that, they'll lose access to medications, whether that be temporary or permanent. We know that the disruption to care is going to be incredibly dangerous, because very often people don't know they've lost coverage until they get to the pharmacy to pick up their medication when they are due for a refill, or they get to the doctor's office to see their provider, and the person behind the desk says, "Oh, I'm sorry, your insurance has lapsed." And then they're not able to be seen on that day. So there's things that you all can do. There are great ways to advocate and action steps that should be taken starting now. So first and foremost, know what your state is doing. I hope that the message you got from this was that every state is different. And so knowing what your local community, knowing what your state has decided to do is essential to knowing how best to help people. Once you know that, help educate people. This is really, we have been talking for 3 years about how this continuous enrollment has been tied to the public health emergency. That is no longer, and that isn't, but it happened during a time when things didn't get out in the news. People were hopefully with families or celebrating, or this businesses, organizations, homeless service providers, staff were taking much earned time off. And so this information has not been conveyed as well as it might need to be. So working on efforts to get this information out into your community, particularly to people experiencing homelessness, but anyone family, friends, community members who are currently enrolled in Medicaid, they need to know this is coming. Assisting those Medicaid enrollees with updating their contact information, even if your state doesn't start until April, update contact information now so that states are able to, so that when they do start communicating, when your state Medicaid office starts communicating about redetermination being due, they are receiving that information. There are a couple really wonderful things in this, when this bill was passed, that do require states to report on. First, they had to meet with CMS to say how they're going to do this. They also have to report on what their disenrollment rates are monthly. So advocate for that transparency with the reporting process. They're going to have to report it to CMS, and it's going to be publicly available, but that's probably somewhere on a website somewhere. Make sure that your communities know what it looks like for them, that there's somebody who is seeking out that information, trying to find what it looks like for you all, to what your enrollment looks like. And then this conversation, that a thread that we'll weave through this: it is never too late to expand Medicaid for non-expansion states. We're going to talk a little bit about the difference of what this is like in expansion and non-expansion states, but it is never too late. So working with advocacy within your communities to expand Medicaid is always an important point to increase access to really much needed care.
Katie?
Yes.
There was a question I'm hoping that you might be able to answer very quickly about where do people find out what their state process is going to be like?
Great question. So ideally, your state Medicaid offices are going to communicate it once their plan has been approved by CMS. So starting with your local offices, your local state Medicaid websites, looking for communication in the mail. You should also have local, your state, if your health centers, if you are affiliated with a health center or you go to a health center, they also will likely be a really great source for this information. So one of the reasons this was tied to the omnibus bill was states were originally only going to get a 60-day notice of when they needed to start this process, and they really wanted more time. And so with this, they have over 90 days from that April 1st date, and they have the opportunity to begin this information campaign now. So unfortunately, it is going to be a lot of finding out who knows. It should be very well advertised, but Medicaid has traditionally used mail as a primary means of communication. So it is possible that that is going to be the way in which you hear about it. And also, as I said, health centers who bill Medicaid will also be receiving information about this process. And if you have enrollment assisters, so people who help with Medicaid applications or even the marketplace applications, they also will be educated and trained on this process. It's going to be a really interesting time because those individuals, state Medicaid offices have had a ton of staff turnover. So many of the staff that work there have never gone through this redetermination process before. So I want to introduce my panelists and have everyone join us. And I'd like to start by handing it off to David, if that's okay. So if David can help frame it for us, this all through the racial equity lens. I want to lay that as the foundation for where we're going to take this conversation as a panel. David?
Sure. Thank you, Katie. I'm very happy to. Just a quick note about my background. Even the people that know me well may not know this aspect of my professional background, but I started my legal career off in the U.S. Department of Health and Human Services, Office of the General Counsel, in their healthcare financing division. So I worked for several years as CMS was my client, and where I reviewed Medicaid waiver applications, Medicaid regulations. And on the other half of the time, I litigated Medicare cases around the country. So this Medicaid issue is very near and dear to my heart. And I think I may be able to give you a glimpse of the federal perspective on Medicaid. As I think everyone knows, Medicaid is a joint federal state program. And so the states have the primary responsibility for implementing it under federal guidelines, broad federal guidelines, and certain federal minimum requirements. In terms of the racial equity aspects of Medicaid, I think it's obviously, as people know, Medicaid's is a program providing healthcare services to the poor. The poor is disproportionately made up of Black folks, to be very blunt. And I think, as most people know, that Black people are 3 times more likely to be homeless than whites. And so this is essentially a racial program. If in very stark terms, it can be even racist in the sense of the administrative barriers and burdens that the states will often impose to keep people off of the Medicaid rolls. So to drill down and look at what's happening here in Florida, for example, which is a non-expansion state. Florida has resisted, I think at last count, some $50 billion in federal money, okay, in order to maintain their, I guess, I don't know what it is, ideological purity, conservative ideological purity. But essentially, Florida has declined about $50 billion in federal money, is now only one of 11 states now, one of a small minority now that has refused to expand Medicaid, has refused to provide access to what's known as that people in the coverage gap. And that's primarily adult males, 22 to 64, who are too old for the child and young adult coverage of Medicaid, but too old for that, but too young for the above 65 and older coverage aspects of Medicaid. But essentially, aside from not expanding Medicaid, what Florida does is provide these really incredible paperwork burdens, administrative burdens, in order to, and this is my speculation about their intent, to purposefully provide, erect these barriers to exclude people from applying. So from a personal example, I've applied 3 times in 5 months and been denied, despite the fact that I have a law degree. Okay, I think I know what I'm doing, but I have been denied 3 times in terms of applying for Medicaid. And so I'm on my 3rd appeal now. And what was my crime? What was my failure? I forgot to check a box allowing consent, financial consent for them to get my bank records. Now understand that my primary source of income is Social Security, and the state has my records and they know how much my income is. But yet they will deny you simply for not checking a box or failure to submit 1 or 2 pieces of paper. And this is intentional. This is a way to frustrate people. Most people are not cognizant or knowledgeable enough to file an appeal. Okay, and even when you do file an appeal, it takes a while to wend its way through the administrative, for you to exhaust your administrative remedies. So it takes a while. But here, and I could go into more detail about not just Florida, but other states such as Louisiana and the like, and even states that have expanded Medicaid that still impose these requirements that have a disproportionate, disparate effect upon racial minorities in order to exclude them from Medicaid. So it's very important for us as we go out into the streets to focus on the most vulnerable groups, the most marginalized groups, the folks who are of African American ethnicity who are being excluded due to these barriers.
Thank you, David. Thank you so much for laying that foundation and groundwork and of our conversation ahead. I'm going to start with a couple targeted questions. The first to Valerie. Valerie, can you talk a little bit about how a lapse in coverage impacts a person's ability to access care, and what types of services are impacted in particular?
Hi, and thank you. So when you think about the lapse of services, and I think you really covered it really well, you're also talking about that housing. And if you think about the last 3 years, how many people lost housing and how many people didn't change their address? And so that Medicaid letter is going to go to whatever address that they have on file. And so when that individual maybe need to go to the doctor and go to see maybe specialty care for something chronic, that's when they're going to come up against, oh, you don't have medical insurance. And then it took you 6 months to get on that list. And when you don't have insurance, you come off the list. And they don't put you back on a short-term list. You start over again. And so that person, for whatever reason that they need that special care, they're going to go without care. And that's a lot. And another thing that came to my mind, I was researching today about Ohio Medicaid, and our deadline is March the 31st. I think that's what I read. But I also was reading about 68% of individuals in Ohio who receive Medicaid are working people. So what does that do for the working people? What is this going to even begin to look like? You know, we're talking about mothers, we're talking about children with special needs. So it's going to be a lot. It's going to be a lot. It really is. And so we have a lot of work to do.
Thank you, Valerie. We sure do. Amanda, I'd like to turn it to you. What are some of the risks for somebody who is near the income threshold for Medicaid, and things that you're worried about for those kind of cuspers, as we call them?
So I'm going to say we're lucky in Washington to have many, many points of contact for people to sign up for Medicaid. And of course, there's the ex parte process. But for somebody who is on the cusp, in other words, maybe $100 from the federal poverty line, which we know is very low. So we know that that right there, the federal poverty line is not enough, especially here, to pay rent or do any of those things and still have money left over. So many times people have specialty medications. Just to use a personal example, my medications are close to $7,000 a month. I thought it was hundreds, but I checked into it. It is close to $7,000 a month. So if I was to hit that guideline or that cusp and be off of services, what would happen, and what happens to many people, is without those medications, they are not able to continue the work, to continue to get the income. And so they will fall back into being so sick or homeless or any of those number of things, and have to get the medical care and then build back up, right? And that treatment, a lot of times to stabilize, takes months. So when they go off their meds, then they're back at the bottom and have to start months again with that treatment. And that in and of itself puts a burden not only on the system, but then we find people who are unable to care for themselves where they would have been medicated and now are facing even more dire circumstances, such as homelessness, a re-emergence of, mental illness that's untreated, substance abuse disorder that's untreated, and many, many illnesses such as cancer, diabetes, arthritis, all of those. So that, for somebody who's on the cusp, that is a very serious issue, because it won't be long until they're at zero again. So there's really this idea of forced poverty and how that affects those that have disabilities that need that. Thank you.
That's great points, Amanda. And some of my work has been in helping people get disability, and that the spend down process, and it is so complicated unnecessarily and so infuriatingly difficult to prove the costs, the need, and as you said, forcing people into poverty to get a benefit that could have helped them from getting to that point.
And even with 20%, say you take an employer's, like your employer's like, here's some medical insurance. Yeah. Many times that's like 20%. 20% of $7,000 is still a hefty chunk, and many people cannot afford that, because you're not going to be completely over the cusp. You're just going to be a little bit. So
Absolutely.
And I agree with her. Even for the working people, that's what we're going to see. We're going to see individuals making a decision: should I work, or should I work, or should I not work in order to keep my Medicaid?
Sure. Good.
So that's, I mean, because now you're talking about if an individual is working and they're on Medicaid, and we're talking about co-pays. It's a lot that's going to go around this. So people are going to have to make a decision if they want to work now. And if they don't work, then here we go with the housing. So yeah.
Ugg is right. Reading in the comments. David, go right ahead.
Yeah, two quick comments. First of all, just to give you a little glimpse behind the history of this, the spin down requirements, in my opinion, are the most horrific parts of Medicaid to impoverish somebody to get a benefit. And I've always wondered where it came from. I first encountered it some 20-something years ago when I was at HHS. And it was actually a compromise that was struck by many of the southern states when Johnson was the then President Johnson was pushing this through in 1964. Basically, the only way that they could get the southern states or southern senators to agree to this massive socialist program for the poor was by including these spin down requirements. So basically, it's just punishing people for being poor and if, for getting this entitlement. And if you don't have the entitlement, they're going to punish you, or at least if you have some assets, they're going to punish you even more. So basically, this was a compromise back in the mid 1960s in order to get this legislation passed. The other point I want to make, and I think several people have noticed this, it's an incredibly complex redetermination process. It's not for the uninitiated, and it's really befuddles lawyers too, but it befuddles people who are experienced in this area. What I would suggest, if you guys don't have full-time case managers who are well versed in this redetermination process, you might want to see what you can do to get folks onto perhaps HMOs, for instance. Okay, I know that, for instance, I can enroll into a Medicare HMO, then I have a case manager who's free, who will get me onto Medicaid. And basically that's what I'm relying on. Let them do the work, okay? And so to the extent that you're in a state that has maybe a Medicaid managed care program that might contract out and privatize this to HMOs, try to let them do the work. Try to see if they have case managers there, because it's their job to get people enrolled. So you might want to use that resource that may be available to you.
I do think people who have done it multiple times have that savvy to know which boxes definitely need to be checked and which words not to use or do use. And so before we open up to everyone in a larger discussion, I want to turn to Linda. Linda, how did having coverage change the trajectory for your family, for the care that your family members received?
Thank you so much. Yes, I come at it from a slightly different point of view. I was a former foster mom and adoptive mom of kids with prenatal drugs and alcohol exposure. And their coverage in the foster and adoptive care system was continuous and categorical. We never had to reapply, and I adopted one, and his medical needs and wants, as myself, the case manager, and the navigator for him, every single want was met. And he is a very successful person now at the age of 36. He certainly has his original birth defects and impairments caused by fetal alcohol syndrome. It's quite severe, but he's held the same job and had the same apartment for 15 years. So I come at it from a continuous point of view in the state of Minnesota. Thank you.
Thank you for sharing your wisdom, and the experiential wisdom is how everyone has managed to get through this. It is because of those who have paved the road ahead of us that have informed and educated us on how to do it. So I'm going to open this up to everyone, and please, to you all out there, use the chat and Q&A feature if there are questions you'd like to ask everyone. Certainly I'll try and answer anything technical in the chat so that we can use this forum to really have these great conversations back and forth. But as to the entire group of panelists, how does the loss or lack of coverage disproportionately impact people with co-occurring conditions? So those living with medical and behavioral health, how do you feel they are disproportionately impacted? Go right ahead, Amanda.
I would say number one, when we look at co-occurring conditions, a lot of times, like, for example, somebody with severe mental illness and we'll say cardiac issues. Many, many times to fix those cardiac issues, you have to be right mentally, right? To go to your appointments, you have to have that executive functioning. When you are underneath stress or you're going through trauma, that executive functioning is halted. And in some ways, so what that does is that's your motivation, that's your planning, that's your ability to go and get things done. Now, somebody may say, I need to go to the heart doctor, I need to go to cardiology and get this fixed. But because they're executive functioning and they're undergoing trauma, they're not going to be able to do that. They're not going to be able to keep up the appointments. They're not going to be able to do that. And as soon as Medicaid is taken away, like say they get to that cusp and that point is happening, they're going to be then forced to pay for the coverage, pay for the medications. And if they cannot do that, their whole treatment, both whatever the co-occurring conditions are, is going to be back at square one, and they're going to have to work their way back up with the medications. Many times this can cause death, especially in those with diabetes and other conditions that have to have regular maintenance or the person dies. So we're really looking at a situation where even if those people who qualified in 2020, we're all facing inflation and this cost and this rise, but that's not reflected in the Medicaid, the federal poverty line. That inflation, that cost is not reflected. So you're going to see more people losing the coverage because they hit that cusp and then falling backwards. And then we're going to have to work from square one. In other words, housing, healthcare, to get them back up. So it's reinventing the wheel over and over and over because of bureaucracy and public narrative.
So if I can mention something real quick, obviously many of the people on this call here are really the secret sauce, the community health centers, the healthcare for the homeless centers. You are, along with street medicine, you're the only avenue that the vast majority of unsheltered folks on the streets have for primary care. And so basically, you guys are it, okay? And then the only other prospect is to get so sick either hypertension or diabetes that you present to the ER, and you sit in the ER for like 8, 9, or 10 hours. So you guys are really the key. Here in Miami, we have a special program called the Lazarus program, where we actually get funding from our Miami-Dade Homeless Trust, our local CLC. It's a special program where they actually go out to the streets and deliver medication, behavioral health, and I think even some psychotropic medication directly to people on the streets, people suffering from severe and persistent mental illness. And at the point that behavioral or mental illness is stabilized, they also have a transitional housing program where folks who are enrolled in Lazarus can come in and get transitional housing long enough for them to get permanent housing. It's very similar to an ACT team, by the way. I'm looking at the chat here, but it's not exactly the assertive community. I forget what the T is. It's not exactly an ACT program, but it's modeled very similar to that, where it's a team. I think headed also by a nurse practitioner that actually goes out into the streets. So So this is I can send folks, if you write to me offline, periodlaw@gmail.com. I'll give you some information on our program, but it's a way for us to do the outreach, to go out there, get people. I think we also have a SOAR case manager who is trained in navigating these barriers to get people connected onto Medicaid. So this is a way, Katie, to directly address your question here. This is targeted to people, as I said, the SPMI, the people with the severe and persistent mental illness population, to deliver their medication, to get them signed up for SSI and other benefits, including Medicaid. So I'd encourage folks to look at programs like that. And you need specialized programs like this. You need SOAR type of case managers. I think everyone knows what SOAR, SOAR. People especially trained in this area, because as I said, it's not for the uninitiated. There's so many barriers, and you'll just be very frustrated jumping over all these hoops and slamming up against these walls.
And one other thing, when you think about the lapse or people not having Medicaid, it's the substance abuse. Because you could go to, if you have a health care for the homeless program, they're going to see you regardless. But the behavioral health medication and the substance abuse medication, those are two I really worry about being covered without Medicaid insurance. Yeah.
I'm gonna move on to our next question, but certainly please feel free in the chat. I'm trying to get some information out as well, but love to have these questions coming in. What lessons do you think were learned in your community by having continual coverage of Medicaid during this time? We know that the highest number of people were insured during the continuous enrollment, and on the flip side of that, the other statement that can be made is we had the lowest uninsured rate the country has ever seen because of this. What do you think are the lessons that we should take away about the value and the importance of that?
More people getting care. That's the healing of our communities.
Mm-hmm.
When more people have care, they get healthier, and thereby the effect on public health or our communities also rises. What we are seeing, as well as Medicaid, though, is a loss of providers due to the COVID-19 pandemic. So while we have high coverage, there's less providers, so it is harder to get in. So I'd say the lesson for that is really working on infrastructure to make sure it all works in tandem, and really having those points of contact. That's so important wherever the person is, whether we've done it at vet clinics, we've done it at our street med team, wherever the people can be, to sign people up and recognize that vulnerability. That's very effective. So that's something I really like here.
Yeah, and I think providers going into private practice, seeing a lot of that, and providers not taking certain health insurance, certain Medicaid coverage.
And that's a form of discrimination of itself, right?
I know.
Discrimination
Yeah,
against
we know.
the impoverished. Yeah.
Yes.
So Katie, this is Linda. I would say in foster and adoption, it really is the foster parents and the adoptive parents' job to manage this and keep continuous all cares. And if, as a person on Medicaid myself right now, or Medicare, over 65, I do make a kind of a job description for myself to navigate myself and get places. And like right now, I haven't had my physical for 18 months, but I kept rescheduling it because of snowstorms in Minnesota. So, I didn't meet that 12-month mark, but I'll get there.
I think, Linda, that highlights that, this theme that we keep hearing is this kind of an expert or designated navigator, for lack of a better word, of somebody who really makes it their mission to get somebody on coverage, to keep them on coverage, reapply all of the times it's going to take in order to get that coverage. And we need so many more of those people, and it is infuriating that that is necessary at all. It just shouldn't be. And that is just to get coverage, never mind the process of actually finding providers who have openings and take Medicaid, and that you can access. And then what happens if you miss an appointment and need to reschedule? How long are you going to have to wait? I think Valerie's point about specialty care is such an important one. My work in Baltimore, we saw regularly specialty care providers wouldn't reschedule a missed appointment. They just, not just because it would have been months and months until their next available appointment, but they had a one strike and you're out sort of approach of, if you don't keep this appointment, we're going to give it to somebody who will. Amanda, please.
Yeah, and that's something that is changing rapidly here, is that punitive approach to appointments, knowing that conditions can cause a lapse in care. And at times that's not necessarily on the person's radar because, they're trying to survive. So that's something I think is really important to fight for, is to stop that punitive action against people. I think that's the word, David, you can tell me better, but I think that's the word that describes that.
I'm sorry, I was reading the chat. What was your, I heard my name, my ears popped up.
I said the punitive action, taking people, kicking them out of care when they can't, when they don't make an appointment. I know that it used to be here, 3 strikes, you're out, right? So like in a year, if you miss 3 appointments, you're out of care. They don't do that anymore. And there's a reason for that, because there's a better understanding of, it's not people being irresponsible. Many times it's not laziness. It's literally a problem in the brain when you're trying to survive trauma.
Well,
And so,
yes, that's beyond cruel when it comes to healthcare services. I mean, obviously, how are you somehow satisfying your duty as a healthcare professional when you're not providing care? You're simply penalizing people and punishing people and denying care for people that simply don't meet your administrative requirements. That's beyond cruel. And if you're a physician, I think that would certainly be a violation of your Hippocratic oath. But unfortunately, we have that same mindset, and I think it's rooted in a cultural bigotry against the poor. When it comes to shelters, for instance, many shelters will banish individuals based upon their failure to comply with certain rules that have nothing to do with safety or striking out against somebody else. Simply, I was banished from a shelter permanently because I didn't meet with my case manager. And please tell me, how does that somehow increase access to housing when you kick somebody out for non-safety related reasons? So we still have that going on today. And I think that same type of punitive thinking can bleed over into the healthcare area as well. As we all know, housing is healthcare. So to the extent that you don't have housing, your health is going to suffer. And when you banish somebody from a shelter because they haven't met with their case manager, or perhaps they violated some curfew or something like that, you're endangering their health. So unfortunately, we still have that going on today. It may not be directly implicated by the healthcare system. I don't know. That's pretty bad when a clinic knocks somebody off the rolls because they've had 3 no calls, no shows. To me, any clinic that does that would be violating their conditions of participation in the various federal programs. I would report that to a regional office. But what they're trying to do is increase their own internal report card. Okay, they want to show that their own internal that they have a very high rate of people completing their appointments, and that makes them internally look good. But by the same token, it really obviously hurts their clientele. So it's really something that doesn't make any sense, it seems to me, if you believe your mission is to help a marginalized, vulnerable group of people to advance in their healthcare status. To knock somebody off the rolls for not showing up to appointments is really undermining that goal. That doesn't make any sense, and as I said, just sounds cruel.
What do you feel, what is your greatest concern about the return of this process? So not just this immediate one-time thing, but the fact that this is now, we are going to go back to this being an annual activity. We've had some great questions that I'm going to try and answer as well, but talking about just the things that are not covered, and the fact that each of you is in a different state, and how what you have to do on the ground looks so different because of how we have taken this federal benefit, entitlement is what it should be, but benefit, and have made it very watered down in places based on local politics.
Mhm.
If I could mention something in a related topic, that people, I think I've seen a couple of times in the chat here, there's a lot of comments in the chat. Peer support, especially peer support, participation and outreach is so incredibly important. So incredibly important. I think somebody might have mentioned how on peer support, I think in the behavioral health context and in transitional housing, kind of helps folks who are unsheltered on the street see how their peers are now benefiting from services. That is extremely important. And I can tell you, as somebody with lived experience, you grow suspicious and distrustful of the professionals, of the doctors, of the police officers. And in fact, police act as predators as much as they act as protectors. But basically, you don't trust anybody because the system has failed you. The system has failed all of us. And so why do we want to trust you when you're simply going to use our social security number? You're going to use our SNAP benefits to enrich yourself or your institution. But when it comes to peers, folks that may have slept right down the block from me and now have overcome some of the challenges of their behavioral health or their substance abuse, and now they actually have that shirt on and they're working. And most importantly, as someone else put in the chat, they're meeting you where you're at without judgment. That is extremely important. That is uplifting. And you can see that this is not somebody who has simply been folded into the institutional, motivations of a provider. But this is somebody who is me. Okay, they're simply at a more advanced stage or a stage where they've overcome these challenges. So I can't overstate how strongly important it is to have an active, ongoing peer support program and have peers within outreach teams. That helps, and that'll help to connect with people. That is extremely important.
And peers could also do the work of enrolling individuals up for health insurance as well. That would be good.
I would say my largest concern over all of this is the fact that medical emergencies many times end in the person being homeless or being vulnerable or even dying. And so when we see this recertification and people not being able to get coverage or not meeting the deadline, what my concern is the infrastructure. The infrastructure in our country is already strained, especially when it comes to healthcare. So then you have people that for right now are stable, but they lose that and that stability goes away. And what does that do when we're already overrun with, this trauma and this societal, really a collapse of sorts? So when we don't register people and they are on the cusp, we're going to have more vulnerability, which also puts pressure on our infrastructure and our healthcare infrastructure. And when we're facing loss of providers and we're facing this huge burden, that's my concern. My concern is that it's going to become an even more critical issue than it was before.
So I'll say my personal concern is that we need universal health care.
Sure.
But I mean, that's a universal concern. But in terms of my own family, I won't always be here. So to be intrusive or to try to jump in and case manage for my son now, he's 36 of the age, it would be inappropriate. And I need him to become a better and better case manager and self-advocate. And yet to teach that when someone has special needs such as he does, you know, it's an art and a science. You know, you don't want to tell him what to do. No one wants to be told what to do. No one ever did. But he needs to, for example, hide money under his bed for dental care that is not covered in Minnesota by Medicaid, Medicare, insurance of any type. For people with special needs, they just extract one after the other, and the face caves in. And I've had it with that approach, and so we are having a dental savings account. But he was so worried for years. Someone will know. The workers will know. They will say, where did it go? Because they actually allot, you know, and tell him how much fun money he can have every week, that kind of thing. So thank you.
Really great insight. One thing that one of the many things that keeps me up at night is, you know, we do all this work to demonstrate, to have these demonstration projects about how Medicaid should and can pay for street medicine. Somebody asked a really great question about this. And so we have the way in which we can get those services covered is to have these projects that demonstrate that they're effective, that they provide quality care, that they avoid many of the outcomes that insurance companies are looking for in terms of lowering costs. And then we decrease the number of people that have Medicaid, and so that it can serve fewer people. And the other is that has been in my entire career as a social worker are the demonstration projects to have Medicaid pay for housing, which is what we are all here and in the business to do, is to end homelessness. But there are, I learned recently about a wonderful program up in the Yakima region of Washington that is one of these demonstration projects of using Medicaid to pay for housing and the supportive services, most, you know, that help an individual remain housed for those that need that level of care. And speaking to, you know, thinking of Linda's family and what happens as our family members age and we are not able to be there to support, this model can serve those individuals and help them remain housed. But residency in those programs are often or at least access to the supportive service is contingent upon having Medicaid. And hopefully, if they are connected with those service providers, they are able to make sure that they don't lapse, or if their coverage does lapse, that they can get them re-enrolled. But as we move the target of what eligibility looks like and what services Medicaid covers, you know, the more they try and gut at the services that are actually covered by Medicaid, the less likely that those programs will be able to meet what is only a growing need. We are at 5 minutes left, so I want to just open to my panelists to make sure we give Megan a minute to close if she needs to. But what have we not talked about that you all would be remiss to leave this conversation without saying? I will turn it to each of you if there's a final statement that you want to make sure everyone on this call hears.
Sure. I'll make a quick final statement. We need to take an intersectional approach. That housing is healthcare, that we integrate teams of peer support, housing, as well as case managers conversant to sign folks up to a Medicaid. And as somebody put into one of the chats here, once you stabilize people, into housing, that a lot of things tend to fall into place. So we need to take that intersectional approach and recognize that housing is healthcare.
Well, and I'd also say that, you know, any treatment plan that you have will have a place where a safe and stable environment. That's actually part of treatment for any illness, is having a safe and stable environment. So
I want to say mine real quick before I start. This one might make me cry. We lost a family member at the age of 57 at Christmas time when she collapsed, and her husband was told, he said, "Thank God, now we can get her the help that she needs." But she had a bleed on her brainstem. And so I will just say, please tell everyone that you know you love them, you care about them, you'll follow up with them. Health is home, home is health. We must hold each other. Thank you.
Thank you, Linda. I would just say we need to take a look at hiring peer navigators to do the Medicaid enrollment.
Awesome. Thank you all. I'll go ahead and wrap us up here. Thanks everyone for your engaged chat, questions, and really just being here and advocating. You know, we say housing is healthcare, but I think, and this is one of the questions too that came through the Q&A, how do we continue to advocate for large scale changes? You know, I think that we all agree on this call, and you could see through a lot of the chat, we all need healthcare. You know, I think that we need to continue to push for universally accessible healthcare that, you know, that provides for all of our needs. We're humans, and all humans have the same needs. So, you know, I know that from a national perspective, as a national advocacy organization, we say this, and it's really true that, you know, anything that you can do to lobby your own personal legislators, your statewide, you know, your statewide legislators, your local, in your city, in your county, or in your congressional representatives, anytime you are able to reach out to them and stress the importance of these issues of healthcare, of making sure that everyone, you know, maybe looking at a model where Medicaid re-enrollment is automatic, as someone suggested, you know, ensuring that we can provide housing for anyone who needs it. These are the things that the more your elected officials hear from you, the more accountable we can hold them. You know, sometimes we say that people don't care, but really this affects all of us. We're really truly grateful today, the National Coalition for the Homeless, for our partnership with the Healthcare for the Homeless Council. Thank you so much, Katie, for helping to organize this discussion. Thank you especially to our panelists who have lived experience, but also just this expertise in the area of the needs of our communities. So thank you, Valerie, Amanda, Linda, David, for your time today and your input as well. And with that, thanks everyone. We'll stay on for a few minutes if you need anything. I know someone had their hand up. I will allow you to talk now, but thanks everyone, and be well.
Thank you for being with us today, and to these amazing panelists. Thank you for your brilliance.
Alicia and Pamela had their hands raised. I think you can unmute if you need to. Yeah.
I'm so sorry. I think that was actually an accident.
Oh, okay. Well, that's okay. Thanks so much for being here.
Yeah, so thanks for having me.
With me. Can you hear me?
Yes, Pamela. Yeah.
Okay. So I'm a consultant working with Julia Dobbins and the National Healthcare for the Homelessness Council, and I lead the. So I'm helping them. I lead a learning network that includes in LA all the medical respite providers, the Medicaid managed care plans, and the hospitals, and been working statewide And I'm wondering if you have seen the letter that CMS released dated January 4th that provides some additional guidance on what services a Medicaid plan can cover and what the requirements are, because I think it's really important for us to understand where the plans are coming from as well, and that they can't provide a service that doesn't have a cost, an ROI cost benefit. So I'm just wondering if you've seen that. No.
Well, yes.
I haven't.
Yeah, so I can send it to somebody if you want me to, and you can send it out to the group, but I have been facilitating these negotiations between the health plans. Was formerly VP of LTSS for a plan. And so I facilitate the negotiations and try to push the envelope as much as I can. And I think that, we can say housing is healthcare till the cows come home, but this is a federal restriction, and
Yes, it is.
in which HUD plays a huge role. And so I think we can't just look to the healthcare entities that do it. We need to bring HUD into the picture and, make sure that the funding is adequate, because the Medicaid managed care plans do not now get funding to pay for healthcare other than the temporary care that we're now doing with them being able to pay for medical respite.
So I'll give you a federal perspective on this. The general feeling within HHS, and you're right, the state plan defines the boundaries of what the state can pay for and state can provide. The feds believe in general that Medicaid is statutorily barred from paying for housing, because the Medicaid program is supposed to pay only for medically necessary healthcare services. But there's a big but here, a huge but, okay? But on the other hand, more enlightened folks, staff folks at Medicaid who do recognize that housing is healthcare, will allow payment for housing under either various demonstration projects. I think they call them 1192 demonstration projects, or section, I forget what it is, Medicaid waivers. So even
the 1115, yeah,
1115. I'm sorry. 1115 demonstration projects, which are statewide demonstration projects, or waivers, which may be confined to specific areas of the state or localities, and waivers actually may have even more flexibility. So you can provide these types of services under a well-defined waiver. And there's a number of consultants out there who have successfully designed waiver programs that will allow, wow, got a lot of people coming on. We have another call coming up.
Yeah, so under the 1115 waiver, they can only pay waivers. They can only pay for the temporary housing. They've made an exception for medical respite. We call it recuperative care in California. And they had to actually move medical respite recuperative care out of the 1115 waiver into the 1915 waiver to even be able to temporarily pay for it. So I think what we need, and maybe, one of your organizations, I'm not familiar with everything that the National Healthcare for the Homelessness Council does, because they do a lot that I'm not involved with. But I think there needs to be a very focused effort on, because there's, you've got 50 different states with different rules and different ideas, and that somehow we need to come together and try to get it at the CMS level, some clarity and some guidance on how we can better incorporate the housing piece into Medicaid, and how we do it, and what the right tools are to get it done. And, or is this a partnership with HUD, and how do we make that work? Because it's very difficult to do the interdepartmental projects that actually meet the needs.
So all I can say in closing, so it looks like another call is starting here.
Oh, no,
Um,
okay, okay,
I
sorry.
can't imagine that 40 people just joined us
Oh, my
at the end of
goodness,
this call.
okay.
But there is no single what was 1115 demonstration project. They vary depending on what it is that you want to do, and so you
Right.
design that demonstration project to meet your needs. And you're right, by its very nature, they're supposed to be somewhat temporary. But I've known demonstration projects, at least unless things have changed in the last few years, that have gone on as demonstrations for 10 or 15 years. Okay.
Wow,
So you
okay,
just
well,
have to
anyway,
kind of keep renewing it.
nice
reauthorize
talking
it.
with you. You know, we're in the trenches together. Have a good day.
You too.
Yeah, thank you,
Bye-bye.
everyone.
Sorry to run over.
No
Okay, bye.
worries.
Yeah, sorry
Have
to
a
run
great
over.
day.